Thank you, Madam Chair, members of the committee. Senate Bill 490 amends let's go with this. Senate Bill 490 amends certain provisions of the optometry law relating to scope of practice, definitions, and credentialing requirements. It amends KSA 65-1501, 1501A, 1509A, 65-1512, and 75-1504. So Section 1 of the bill amends KSA 65-1501, the practice of optometry, by adding a number of procedures to the scope of practice. In subsection A3 of the bill, the prescribing, administering, and dispensing of pharmaceutical drugs has been amended to include all routes of administration except intraocular injections and the use of medical devices for the examination, diagnosis, and treatment of ocular conditions. The scope of optometry has been amended to add the removal of non-perforating foreign bodies from the cornea, conjunctiva, or eyelids, removal of eyelashes, scraping of the cornea for diagnostic tests, smears, or cultures, the dilation, probing, irrigation, or closing the tear duct structure of the eye, expression of conjunctival follicles or cysts, debridement of the corneal epithelium, incision and curettage of a chalazion, removal and biopsy of skin lesions without known malignancy, laser capsulotomy, laser trabeculoplasty. That one I knew was going to get me. And laser peripheral iridotomy. The bill also adds that the scope of practice of optometry includes procedures that are not specifically prohibited as being part of the scope of practice and that are within the scope of a licensee's education and training and that are authorized pursuant to rules and regulations adopted by the Board of Optometry. Subsection B specifies that the practice of optometry does not include retinal surgery, penetrating keratoplasty, or corneal transplant, administration of surgery under anesthesia, and the remaining items on page 2, lines 64 through 23. Section 2 of the bill amends KSA 65-1501A definitions by removing the definitions of topical pharmaceutical drugs and oral pharmaceutical drugs. And you can see that there's been some drafting cleanup in this section as well. Section 3 of the bill amends KSA 65-1509 to require the Board of Optometry to develop and establish credentialing requirements for a licensee to administer or perform the procedures that I stumbled through earlier. Section 4 of the bill amends KSA 65-1512 to state that Article 15 of the Kansas statutes annotated shall be known and may be cited as the optometry law. And finally, Section 5 of the bill amends KSA 75-1504 and requires the Board of Optometry to maintain and make available to the public a directory listing the names and addresses of all optometrists licensed by the board. If enacted, the bill would go into effect on July 1 of this year, and I can stand for questions.
Committee, are there questions for Eileen? Senator Petty.
I just think Eileen did such a great job going through those procedures. Maybe she needs to practice it one more time.
I stayed at a Holiday Inn last night so I could pretend to be a doctor this morning.
So it's great.
Any questions for Eileen? Seeing none, thank you, Eileen. We're going to be the proponents of the bill, and I had shared with both the opponents and proponents that everyone would have 2 minutes. We do have a request that one of the proponents is going to stand aside so that the other proponent can have a little longer. So if you could tell me if you're the proponent that's going to have the longer time, I would appreciate that. So we're going to begin with Todd Flesher.
Good morning. My name is Todd Flesher. I'm the Executive Director for the Kansas Optometric Association. I'm happy to be here before you today in support of Senate Bill 490, which modernizes the optometric scope of practice to reflect current education and training. The Kansas Optometric Association has been around for just under 125 years, and during that time we have served the profession to make sure that optometrists have the tools and education and other resources necessary to make sure that they can take care of the best their patients to the best possible. During that 125-year history of the K-Way, the optometric profession has changed pretty dramatically. Just like other healthcare providers, healthcare is a lot different than it was 125 years ago. Because optometry is a legislated profession, however, we come before you periodically to update the Practice Act to reflect current education and training. That's actually what we're here for today. The most recent change that's of any significance to the Optometric Practice Act was in the late 1990s. As you can imagine, healthcare has changed a little bit since then. The scope of practice or the training and education of optometrists, and also the standard of care has changed a little bit since then as well. So the goal behind this bill is to make sure that optometrists are able to practice to the level of their education and training. Optometry schools, every single college of optometry in the country has attested that they are providing training on the procedures that are outlined in this bill. And I do want to clarify a couple of things that the revisor did mention. While the bill does amend language as far as specific procedures, foreign body removal, debridement of the cornea, those kind of things are actually already in our Practice Act and have been for about 30 years. It just amended the language the way that it's all referenced in there. So that is actually something that is actually current practice, and it is being done in optometry offices around the state. And quite honestly, probably a lot of the foreign body removals are done by optometrists because they're spread out around the state. So it is something that's already part of the Practice Act, and I just wanted to make that clarification. The reason that this is an important issue for us and why is this important now, all right, well, thank you very much. I appreciate it.
Next, we have Shane Canner.
Thank you, and I'm going to use a little extra time. So, thank you. Madam Chair, members of the Senate Committee on Public Health and Welfare, my name is Dr. Shane Canner. I'm an optometrist in Southeast Kansas. My group provides clinical care, call services to 2 hospitals, and we're actively involved in clinical research. I'm here today to support SB 490, the modernization of the scope of practice of optometry. This bill outlines procedures that optometrists are trained, educated, and certified to do. These procedures are specifically outlined. They include removal of skin lesions, injectable medications, and 3 distinct laser procedures: a YAG capsulotomy following cataract surgery, SLT quickly becoming a first-line therapy for glaucoma, as well as a PI. The bill also excludes procedures that we are not trained to do, and I think that's an important point to make. I would like to say that with my geography, I can drive 30 miles to 2 neighboring states and perform all these procedures as an optometrist. Any profession that begins to modernize their scope of practice must discuss 2 points: education and safety. I will focus on education. The last significant modernization we had was 30 years ago. Before iPhones, Google, streaming TV existed, we were still going to Blockbuster. Think of the technology that's evolved and the changes in educations that have occurred. As an optometrist, I attended 4 years of optometry school, following 4 years of undergraduate school. I had 10,000 hours of clinical education and 2,000 proctored patient encounters. During that time, I received a background and foundation in pharmacology, clinical care, pathology. Interestingly, I was trained in most ODs across the state to handle pre- and post-operative care for our surgical patients beyond those outlined in the scope of practice. And I think it's important to know that we've handled those complications as they arose. Not only did I learn the academic skills needed, I learned the physical skills needed, working with a microscope daily or a slit lamp, using a gonio lens, and removing embedded foreign bodies. Because of this, we are well-trained, educated, and certified to perform the procedures mentioned and outlined in SB 490. Current graduates are all certified at the time of their graduation. Us older gray-haired providers did learn these skills through a CE course, much as an MD would through a CME course. Not simply did we learn them there, it's because of the foundation we had with our training. And we can say that this training is adequate based on 11 states having optometrists perform these procedures, with 100,000 cases being done with no increase in complication rates. As we look at our state, we need to realize that we see a declining number of ophthalmologists in the state and only 480 residents a year completing their training across the country. Also, the average age of ophthalmology in the state of Kansas is 61, and they're not geographically diverse. As you consider this bill, I would like to point out as well, this is not a question of medical school versus optometry school. This is a question of, does optometry school train our providers? Does our state board assure that our providers are proficient in these procedures before we deliver them to the citizens of Kansas? And that answer is a resounding, definitive yes. So I ask for your support of SB 490 to ensure the quality and access to all Kansas patients to the eye care they deserve. Thank you.
Thank you very much. And next we have, and if I say your name incorrectly, please correct me, Derek Bryant.
Good morning, Madam Chair. My name is Derek Bryant. I'm a native Kansan from Winfield, Kansas, and I currently serve as the American Optometric Student Association President-elect. I'm here today to ask you to vote yes for Senate Bill 490 and to let you know why it's important to Kansas students at all optometry schools. First, regardless of optometry school, Kansas students are trained to perform the procedures outlined in Senate Bill 490 and want to practice at this level when they graduate. We surveyed Kansas students, and 90% stated that scope of practice is an important factor when deciding whether to return to Kansas or not, and 96% said they'd be more likely to return to Kansas if scope modernization was passed. Just like you, I want to see our state thrive and be an attractive place for optometrists to return to. Second, as someone from Winfield, Kansas, a town only 25 minutes from Oklahoma, I'm able to practice to my highest ability and provide my patients with a higher level of care in Oklahoma, but not in Kansas. With Senate Bill 490, we aren't asking to do something that's new to optometry. We're simply asking for deregulation so that we can perform the procedures that we're trained to do and licensed to do in neighboring states like Oklahoma, Colorado, and Arkansas. Finally, Senate Bill 490 helps prevent Kansans from crossing state lines when care could be provided by a highly trained optometrist in their hometown, but our only barrier to this issue is the current scope of practice in Kansas that doesn't allow for these procedures. I appreciate your support, or I would appreciate your support for Senate Bill 490, and I appreciate your time and your attention today, and I encourage you to pass it out favorably. Thank you, and God bless.
Thank you. And next we have Kathleen Holthus.
Thank you, Madam Chairwoman, for the ability to talk today. My name is Dr. Kathleen Holthouse. I am an optometrist practicing in Wichita, Kansas, and I am testifying in support of Senate Bill 490. I'm a 2019 graduate of the Oklahoma College of Optometry, trained on procedures outlined in this bill. I also had the ability to practice all of these procedures on patients while in school. I'm unable to perform these in Kansas due to limitations on our scope of practice. You will hear arguments against the scope modernization today that we cannot perform these procedures effectively or safely. One such procedure is called a YAG laser capsulotomy. In 2018, I, alongside multiple optometrists at the college, performed a study on the effectiveness and outcomes of YAGs performed by optometrists. In 2023, this study was published in a peer-reviewed journal article called Optometry and Vision Science. The study contained 92 eyes of 79 subjects, a number of eyes greater than the majority of papers cited in our study. Results indicated subjective and objective improvement in patients' vision, and no significant adverse outcomes were reported. The rate of complications is associated with energy used, and the total energy used by optometrists is comparable to those of our YAG studies performed by our counterparts. This study demonstrated YAG capsulotomies can be performed effectively and safely by optometrists with minimal risk and significant benefit to our patients. I want to provide the best care to my patients, and limiting my scope prevents me to do this. I today encourage you to support Senate Bill 490. Thank you so much.
Jason Rogers.
Good morning. My name is Dr. Jason Rogers. I'm an optometrist, and I practice in Gardner and Overland Park. I graduated in 1995 and became licensed in Kansas and Oklahoma, and I maintain license in both states. Before graduation, I received training and education on the procedures that are outlined in this bill. Oklahoma allows these procedures, so this afternoon I could drive to Oklahoma and actually perform these legally on patients. I know you've heard about safety concerns, and here are a few facts that I'd like to bring up to you. As you heard mentioned earlier, these procedures are being performed in multiple states by optometrists under their existing practice acts. Over 100,000 procedures have been performed without unexpected complications. Consider professional liability insurance rates, medical malpractice insurance rates. States that allow these procedures have rates that are the same as what we pay in Kansas. The Oklahoma rates are exactly the same as Kansas with a history of 30 years of performance there. If you review the data from the National Practitioner Data Bank, a repository of malpractice claims that are listed out by state and by provider type, if you look at Kansas data, there have been 8 cases involving optometrists since 1991 and none since 2011. And those 8 cases represent 0.09% of all malpractice cases that have occurred in the state of Kansas since 1990, 0.09%. So it's also important to recognize those last 2 points, that optometrists are held to the same standard of care as ophthalmologists. So in closing, the data points to the fact that optometry is a proven track record of providing safe and responsible care for our patients. So I ask for your support of Senate Bill 490. Thank you.
Thank you. And finally, our last proponent is William Wilk.
Good morning, Madam Chair and members of the committee. My name is William Wilk, Senior Director of Government Affairs for the Kansas Chamber of Commerce. The Kansas Chamber appreciates the opportunity to provide proponent testimony to Senate Bill 490, a bill modifying the scope of practice for optometrists. As you've heard, Senate Bill 490 would allow optometrists to perform procedures they are trained to do in optometry school. Medical technology advancements have enhanced and continue to improve for patient care and, most importantly, patient outcomes. Unfortunately, our state statutes for optometrists have not kept up with the education and medical technology advancements. Senate Bill 490 would increase the access to care for Kansans seeking optometry treatment and would save the patient time if optometrists were allowed to perform these procedures. We also believe the passage of this legislation would allow optometrists and their practices to recruit and retain optometrist doctors. This legislation would allow graduate optometrists to practice the skills they are provided in their training and education. It is important to note Kansas would not be the first to modernize their scope of practice. 11 other states, including Colorado, Oklahoma, and Arkansas, optometrists are allowed to perform these services for their patients. The Kansas Chamber will continue to advocate for the reform of our healthcare statutes to keep pace with the advancements of medical technology while not sacrificing the safety for Kansans seeking and receiving treatment. This is simply allowing optometrists to perform procedures they are trained to do. Thank you for the opportunity to testify today, and I'm happy to answer any questions at the appropriate time.
Thank you very much. Committee, this concludes our verbal proponents. We do have 2 written testimonies, and we have about 5 minutes for questions. Are there any questions for our proponents? Senator Steffen.
Thank you. I'd probably direct this towards Dr. Rogers. You quoted the National Practitioners Data Bank, and I think it'd be pretty easy to compare closed claims in Kansas versus Colorado versus Arkansas and Oklahoma. Have you done that? Do you have any feedback on the per capita incidence of malpractice claims across those states?
Thank you, Senator. The only information I have is Oklahoma's rate of their percentage of malpractice cases versus their overall state was 0.55% during the time. I don't have data on per capita incidents or in the other 2 states either. I only looked up Oklahoma data.
And what were they in Kansas?
0.09% of all the malpractice cases in Kansas.
Of the total.
And 0.55, yeah.
Okay. All right, thanks.
Thank you.
Senator Erickson.
Thank you, Madam Chair. This is for just any of the proponents. Can you tell me, I mean, there's a lot of medical terminology. What specific procedures are outlined in the bill that you want to be able to perform that you can't currently do?
So the first is the removal of skin lesions or treatment of chalazion, which is an impacted gland on the eyelid. So concerning lesions could be sent for biopsy if indicated. And it's interesting to me because we currently manage those patients now. We're following them clinically. We just send them off if the lesion needs removed. So we're the one responsible and held to the standard of care of making sure of identifying an at-risk lesion. Injectable medications could serve a variety of roles depending on the situation in our practice. And then finally, the 3 distinct laser procedures. The first, following cataract surgery, patients can develop a haze. We use a laser to remove that haze. It's very straightforward. It's a procedure commonly done in Kansas as well as any other state. SLT is the utilization of a laser to increase outflow from the eye to lower pressure. It's a treatment for glaucoma that's becoming more first line because it's easier and it has better compliance than many of the topical methods we currently use. And then a peripheral iridotomy is a procedure for a subset of glaucoma patients. Please realize we're already managing and treating these glaucoma patients today. This isn't a new change for us. It's delivering a procedure or providing a procedure for our patients that improves outcomes in some cases, definitely improves compliance in some cases. And as far as a YAG capsulotomy, it's a common occurrence to need that after cataract surgery. If you think of where I'm located in Pittsburgh, Kansas, we do have an ophthalmologist that comes to our clinic 1 day a month. And so a patient needing this procedure may wait a couple months to be seen and the procedure the next month. Or they'd go travel somewhere remotely that could be 2 hours or an hour and a half away. Many cases, these patients aren't driving, and so a family member is missing work. While this is something I could do in my clinic simply and straightforward, and I'm currently managing the complications that would arise, even though they're at an exceedingly low number in my practice.
Thank you, Doctor. Thank you, Madam Chair.
Senator Holster.
Thank you. I think maybe my question would be best for Todd. Just based upon the wording of this bill, would this allow the Board of Optometry to approve additional procedures in the future?
So we would give them the flexibility. So there's those exclusions that are already outlined in the bill, but it would be additional procedures as new technology comes out to treat conditions that they're already treating. For example, one of the procedures that's outlined in the bill, I think right now, is actually light adjustable lenses. It's using light to adapt an intraocular lens. It's a new technology that's come out. We actually took that procedure to the state board because ophthalmologists were actually asking if optometrists could do this. We took it to the state board and they said, you know, we're kind of vague on whether this is something that's within the law, so it would be something that if you wanted to change the law, that'd be great, but if not, that we just are not comfortable. So they have that discretion to evaluate new technology, new procedures, and say, is this within the existing scope of practice? And if not, then they tell us, then we have to come to you and ask for a scope modernization. If it's not, if it's currently within their scope and their education and training, then they would. So does that answer your question?
So, and
Okay.
I have a follow-up that kind of goes along with that. Would practices then be required to have the same level of medical liability and participate like in the healthcare stabilization fund so patients have some right of recovery?
Sure. So optometrists actually already have to have malpractice coverage. I think they have to have 3 million coverage is the technical term. It is something we currently do not participate in the healthcare stabilization fund. We used to, but we actually withdrew out of that many years ago because optometric malpractice insurance is very easy to obtain and it's affordable, as Dr. Rogers mentioned. So we haven't had that, but there is appropriate protections in place for the public. And if there's any concerns like that, it is addressed.
Thank you. Our last question is from Senator Baumgartner.
Thank you, Madam Chair. And Todd, I think you could probably answer this, or one of the doctors could as well. The criticism that I've heard from the opponents is that the state board testing doesn't cover these procedures. So talk about national boards versus state boards and explain why.
So the current state board testing would not cover these procedures because they're not currently allowed by optometrists in Kansas. So they would have to adapt the state board to provide that. However, all students graduating from optometry college do have to take national boards to prove competency in these skills. So the state board is on top of that.
So Madam Chair, would you clarify, so are these procedures covered in the national board?
They are correct.
Thank you, Madam Chair.
Thank you very much. That concludes the proponent testimony. And now we will move to the opponent testimony. We'll begin with Representative Clifford. And before we begin, Representative Clifford, we appreciate that Denise Hugg has turned her verbal testimony to written to give you 4 minutes rather than 2.
That's correct.
You may
Thank you, Madam
proceed.
Chair, and Chair Gossage and members of the Public Health Committee. I'm Dr. Bill Clifford. I'm a board-certified ophthalmologist We actually recertify, and I've recertified 3 times already and will likely do it once more during my career. I'm also held to a very high standard. We have 50 hours of continuing education each year. That doubles what optometrists would have and dwarfs any other profession. Turn. I'm here for our patients, not our profession. Our patients have no lobbyists in the halls. They're not represented by powerful business interests, and they sometimes have no voice. And I'm here to give them voice today. Optometry is a profession I very much respect. They're excellent at refractions. They provide glasses and contacts and some medical eye care. This is a picture of a typical optometric office, which as a business model is retail driven. This is my waiting room. I've taken an oath to heal patients, to comfort them. We are there not to sell things, but to take care of their eye problems, their medical problems, and their surgery. This is my world. I see patients from 6 states because I'm in far southwest Kansas. To improve access, we actually have satellite locations in Lamar, Colorado, and northwest in Colby, Kansas. We have 4 surgeons, including our recently retired founder, and we've always had an employed optometrist. We see patients from about 40 referral optometrists, so I'm well aware of their work. I want to describe 3 patients briefly. Nothing can be more fundamental to eye care than a red eye. This red eye patient was taking care of a previous employed optometrist in our clinic for 2 weeks without resolution. She asked me to come see the patient, and as I proceeded to that patient's room, I saw the eye slightly bulgy and told her to ask the patient if they heard a noise in their ear. And indeed, when we went in the room, the patient said, yes, I had a fall a month ago, and since then I've had this swishing noise in my ear. Well, this is a bleed in the brain. It's called a cavernous sinus fistula, or CC fistula. It's both sight-threatening and life-threatening. Now, I wasn't smarter than an optometrist, but I was better trained. I had neurosurgery during medical school. I'd spent time in a stroke ICU, and I knew that this patient needed urgent referral to the University of Kansas. The second case is the aforementioned YAG capsulotomy to treat this condition you see on the left. Lower right is a normal left retina. On the upper right is a retina with a 4-micron hole, 0.4 of a millimeter. We work in a very small space and it requires absolute precision. This patient was treated by an out-of-state optometrist and accidentally the laser was fired through their center of vision. This patient came in saying that she could no longer see her own reflection in a mirror, only the frame, and this is permanent. Finally, I have permission from one of our colleagues to discuss his care. As you know, several of our colleagues, I think 4, have had retinal detachments in the last 2 years. Our colleague developed floaters the day after our recent Martin Luther King holiday. He went home and saw his local optometrist who diagnosed an inferior break in the retina. He had me call her and also call a retina specialist who was to see the patient on referral routinely a week later. Unfortunately, when he saw the retinal specialist, he had a superior detachment with a tear, not an inferior break, requiring emergency surgery. I actually continue to follow him, and we do not know his visual outcome. As you consider Bill 490, I ask you to focus on our patients. Let's not let lawyers decide the standard practice. Let's protect our patients and our constituents. Thank you.
Thank you. And next we have Mary Champion.
Good morning, Madam Chair and members of the committee. Thank you for the opportunity to speak. My name is Dr. Mary Champion, and I'm the president of the Kansas Society of Eye Physicians and Surgeons. You've just heard Dr. Clifford speak about some of the potentially serious complications of the procedures outlined in this bill. And you will hear from Dr. Unruh, and you have Dr. Denise Hugg's written testimony about the differences in the rigor and depth of the training between optometrists and ophthalmologists that make us uniquely qualified to care for these medical conditions and procedures. There is no good reason to change the standard of care in the state of Kansas. 97% of Kansans live within an hour's driving distance of an ophthalmologist, and 92% live as close to an ophthalmologist as they do a Walmart. There is no evidence that optometry recruitment or retention into the state of Kansas at this time is being hindered by our standards, the same standards shared by a majority of states in the country. In the last 10 years, there's been a 24% increase in the number of optometrists in the state, while there's only been a 2% increase in the number of, in our population. Kansas has more optometrists per capita than 47 other states, in more than all of the states in which laser privileges are being granted. There is no evidence that people are leaving the state or choosing not to come to Kansas to practice because of our standards. Every week when I see patients and I explain to them the procedures or the surgeries that we need to do, they ask me, how many of these have you done? Are you doing the one for me? Are you doing this for me? And what people really want to know is, are you qualified to do this to my eye? This is my vision. Our current standards protect our patients, and they ensure that qualified surgeons are doing these procedures. So like Dr. Clifford, I stand before you on behalf of my patients, on behalf of our patients, and for Kansans, and ask you to vote no against SB 490 and uphold our standards for Kansans. Thank you.
Thank you. And finally, Zach Unruh. On WebEx, can you hear us?
Yes, I can hear you.
Please proceed, and you do have 2 minutes.
Madam Chair and members of the committee, my name is Zach Unruh. I graduated optometry school in 2010 and practiced for 7 years in rural Kansas before going back to medical school. In 2021, I began a 4-year residency in Texas at Baylor Scott & White Health for ophthalmology residency. Ophthalmology is a hyper-competitive specialty to match into. A typical day during second year of medical school included a full day of lectures, labs, patient encounters, and studying for the organ system block that we were covering. In addition, I woke up at 5 a.m. each morning for that year to study for step 1 of the medical board because an average score on that test would have limited my ability to match into an ophthalmology residency. My second year of residency, I spent an extra 20 hours outside of clinic studying for a weekly conference, preparing for grand rounds and journal club, practicing in the skills lab, and taking call 2 to 3 nights per week. For 2 months that year, my responsibilities involved seeing urgent referrals and hospital consults for vision-threatening and sometimes life-threatening pathology. I've logged over 2,000 primary patient encounters and over 300 procedures and will likely triple that before graduation. In optometry school, the bulk of direct patient care came during my final year of training, and it was in community clinics as a mix of routine eye care, treating chronic conditions, and learning to recognize ocular emergencies and referring as appropriate. The stark difference in hours of training and quality of experience is important, but the largest divide in my mind lies in the mindset and approach to healthcare as a proceduralist versus a primary care provider. In the ability to not only handle unexpected problems during a procedure, but to anticipate how that procedure may impact future care, and in some cases modify or eliminate other options for that patient down the road. My wife, who's a current practicing optometrist, can identify a time last fall when I began thinking as a surgeon rather than an optometrist. Thank you for your time.
Thank you very much. And committee, that concludes our verbal testimony from the opponents. I would direct your attention to written testimony. And now we have about 5 minutes for questions for the opponents. Do we have any questions from the committee? Senator Blasey.
Thank you, Madam Chair. It's for any of the opponents. You guys went through some scenarios of patients needing care, and I guess my question might be about standard of care. The things that the optometrists are asking for, are most of those things emergent, non-emergent? I mean, one criticism I've heard is, you know, we have patients that can't get an ophthalmologist. So I'm just curious, if there's an emergency today, are patients in Kansas able to be seen by an ophthalmologist?
Absolutely. Our practice has a rule that we see patients emergently. Every optometrist who refers to me has my cell number. In fact, while I'm here at the State House, I get photos and requests for referral into my practice. So only really 2 of the things contemplated in this bill would be a real ocular emergency, and that has to do with angle closure, glaucoma, and pain in the eye, and we always see that patient immediately. We actually have a rule regarding the more benign procedure of the eye capsulotomy. We have a 2-week rule. We try to get patients within 2 weeks. I can't vouch for other practices, but that is the standard to which we practice.
And I will say that, I take, primary call at a level 1 trauma center. So we see a lot of eye emergencies triage from all over the state of Kansas. And for laser peripheral iridotomy, for acute angle closure glaucoma, Every single time somebody's in the emergency room for that, we are able to medically stabilize that patient. And in fact, it makes the laser PI safer when the cornea clears up, and we can do that procedure, in the hours following in clinic. So there's not a procedure there that I would think that we would have to do immediately that we cannot stabilize medically to get to an ophthalmologist.
Next, we have Senator Thompson.
Thank you, Madam Chair, and this is for any of, Dr. Clifford. It's fine. The proponents of the bill talking about being able to practice to their level of training. So I think that for us, who we're non-practitioners, we don't know where that gray level is with regard to the safety of the patient. I'm assuming that this expands the scope to the point where you believe that the safety of the patient is at risk based on these additional practices that they're asking to include?
Absolutely. In addition, this bill is exclusionary, as Senator Holscher pointed out. So any procedure that comes along in the future could be approved by the Board of Optometry. There are two things contemplated in this bill right now for which I have not yet been trained. So to claim training in all these procedures is not correct.
If I could follow up just one quickie.
I'm so sorry.
Okay.
We've got to stick with time. Thank you, Senator Thompson, for your understanding. Senator Petty?
Thank you, and you could just stay there, Senator Representative Clifford. I was, two questions. One, and maybe you've kind of answered this already, but how would this legislation change your relationship with optometrists?
Well, certainly even being here today puts my relationship at risk. But I have plenty to do in Western Kansas, so it's not about keeping me employed, it's about keeping patients safe.
And you already have optometrists in your practice?
We have one employed optometrist, yes.
And then lastly, how much negotiation has gone on between the ophthalmologists and optometrists concerning this bill?
So to their credit, optometry came to me with an outline in November of what they proposed to add. Unfortunately, we did not see the language until 2 weeks ago. And so there was not time for negotiation. I will say in the bill, there are things like cataract extraction, they're excluded. Well, right now we have a laser which can externally soften the cataract, and this bill would not exclude optometrists from doing that. I have not even been trained to do that yet.
Thank you.
Senator Baumgardner.
Thank you, Madam Chair. Two quick questions. One, how many ophthalmologists are there in the state of Kansas licensed and practicing?
I think between 160 and 180.
Okay, so 160 to 180 in Kansas. And how many of those are in our major populated areas like Johnson County and Sedgwick County?
I think just like most other physicians, the majority are in Wichita, Topeka, Kansas.
Okay, and so the other question that I have with regard to some of the claims that you made, Dr. Clifford, with regard to there are certain things that you haven't been trained in, but certainly ophthalmologists as well as optometrists could get continuing education and specific training for procedures that you perhaps have not had the training for. Is that not correct?
That's correct, but I have a basis to go on. I don't do anything today that I trained to do 30 years ago. It's all different, and that practice has evolved. I go overseas to learn some of these techniques. I go to the clinic of fellow colleagues. I go back to university. I don't go to a hotel for a weekend to learn this.
The location to me isn't as important, but I think that it would be fair to say that even Derek Bryant from Winfield is receiving training today that wasn't available to ophthalmologists as well as optometrists 20 or 30 years ago. Thank you, Madam Chair.
Senator Holscher.
Thank you. It seems like a fairly complex topic that we're giving everybody 2 minutes to discuss. So I thank all of you proponents and opponents for being here. In light of that, is there anything that was overlooked or not addressed in that short time period?
I hope that you have an opportunity to read Dr. Hugg's testimony, and I wish that Dr. Unruh had a little more time. There are really stark differences in the way that we train. 95% of current optometry students are attending optometry school in states where laser procedures are not allowed. So as somebody who went through that training, I don't know how to adequately train somebody who is not allowed to perform that procedure in training on a human being. The tissue that we're talking about is a fraction of a human hair. So I think there is much difference in the depth of the training and the rigor of the training that I hope comes through in those testimonies.
Senator Steffen.
Thank you. I appreciate and agree with your concern for the patients, but the reality is doctors are recruited to an area to work and to be busy. And if you take away these procedures from the ophthalmologist, what's going to happen to the patient volume in ophthalmologist's office? And then what are the upstream ramifications to recruiting ophthalmologists in Kansas?
Well, Dr. Champion's at the university, so she might have a bird's eye view of that, but it certainly would put a damper on the desire of ophthalmologists to come to Kansas.
It is a question that comes up with our medical students when they're trying to decide which which specialties they're going to apply to. You want to know that your profession is protected.
Thank you. I would like to thank all of the doctors who took time away from their patients to be here today. We appreciate the testimony. Committee, this concludes our hearing on Senate Bill 490. Now we will move our attention to completing what we had started and recessed working Senate Bill 352. Give you a moment to pull that out. We had started with amendments. And are there additional amendments? Senator Steffen.
Well, let's refresh our memory a little bit. Did we finish the amendment I gave? Was that amendment completed, or were we still reconciling?
We had recessed that at that point. So do you want to continue with that amendment?
Well, I would, and I would do that via a replacement amendment.
Okay, so you have a substitute amendment for that amendment?
Yes.
All right, do you have that prepared for us today?
I trust that the never-resting Jenna has it for us.
Bless her heart. Okay, and Jenna is pulling off her paperclip, so I think she has it ready.
Oh, you did? Oh, right in front of me.
Would you like to begin explaining the amendment while it's being passed out?
I would be happy to. On page 2, we would strike lines 6 through 12. And we'd strike lines 17 through 25. So the difference being we would leave lines 13 through 16.
And would you explain
and lines
to the committee why you that determination?
Well, what we're leaving, this idea to make sure that the hospitals don't require more stringent policies for visitors than they do employees. I think that's fair. And then on the other side, you can't have visitors come in expecting to go into an isolated area without appropriate protection on as well. So it just covers both end of the isolation aspect of this. It leaves that in place. And then from there, we did add that for patients under 18 years of age, a parent or guardian shall be allowed to accompany the minor patient at all times. I thought that's what your plan was. And so I think that has absolute merit and certainly warrants being included in this.
Is there discussion of this amendment, committee? Seeing none, are you prepared to move your amendment?
So moved.
And we have a second from Senator Baumgartner. All in favor say aye.
Aye.
Opposed? The amendment has passed. Do we have other amendments before we vote on this bill? Senator Blasey.
Thank you, Madam Chair. I have an amendment that will affect page 3, number 2, paragraph 2. I'll wait till everybody gets it.
Okay.
This amendment removes the restraints the hospitals have to sometimes apply to patients. Unless someone can correct me, I don't think any hospital is just restraining people with restraints just willy-nilly. You know, I have a wife who works in a hospital. I have friends who are physicians and nurses in hospitals, and the stories are unbelievable. We have patients who have broken a jaw recently of a nurse in my community, just got violent, and sometimes you have to be restrained. Sometimes you have to wrestle patients to the ground because they get aggressive. We have a lot of behavioral health challenges in one of our hospitals in my community, and sometimes things get physical. And so without this amendment, I believe that opens liability to a hospital who's trying to only secure the patient, other patients, and the staff at the hospital. One other concern, you know, I saw in here was it says that you can't be placed in a involuntary isolation or something like that. If I can find the line on that. But anyway, we have patients who are throwing feces at our nurses and our staff, and they're yelling profanities, and sometimes you have to move them to a separate room. And I believe without this amendment, that would not be possible. So that's what the merit of my amendment is.
Discussion committee. Senator Stephan.
Thank you. You know, restraints is a very, very touchy situation in hospitals, and I know they do work very carefully to do that appropriately, and I do think it is pretty common that a physician order is basically mandatory to do that. Yeah, frankly, I see this 6 of one, half dozen of another, but realize that hospitals and physicians, nurses, everybody in healthcare has always been very sensitive about that. And that with the goal being to not do it inappropriately, but that's kind of like beauty. It tends to be in the eye of the beholder.
Other comments, committee? Senator Petty.
Thank you, Madam Chair. Jenna, I also had an amendment. I think it's the same thing. Yeah, still. I agree with Senator Blasey that the issue of restraints is not one that's taken lightly by medical providers, but is absolutely necessary for the safety of the patient and the provider.
I personally don't read this, that it does say they may only be imposed to ensure the safety of the patient, et cetera. Jenna or Eileen, is there anything else in law that you could tell us already restricts the use of restraints?
Yeah, well, I'm not aware of anything in the healthcare setting particularly, although this is adopted from the federal language regarding adult care homes, and so that would be in place at the federal level. If there's other state restrictions, I'm not aware of them immediately. We can look into it and get back to you.
Any other comments, committee? All right. Yes, Senator Baumgartner.
Quick question for the carrier of the amendment. Are lines, halfway through line 11 through 15, are those being removed simply because it doesn't include the protection of a healthcare worker?
Lines 11 through 15. I mean, primarily, it's silent on, obviously it mentions patient and other patients, but yeah, providers are silent. However, I just don't think hospitals are locking people up and restraining them just for the sake of doing it. So I just feel like the whole provision's unnecessary.
Thank you, Madam Chair. As a follow-up, I think that was part of the testimony, that the patient for which this bill is named for was restrained. Thank you, Madam Chair.
Senator Stephan.
Yeah. I would disagree. The history of hospitals has been the inappropriate use of restraints. And that has been a movement over the last 30 years since I came in. When I started, restraints were used very willy-nilly, caused lots of problems, and that whole process has been looked at. You know, I am sympathetic to providers not being in there, but I really, as I look at this and have the opportunity to think about it, I don't think this is a step in the right direction, because I do think that I did hear about that frequently in regards to COVID. These patients were being restrained. They weren't being brought water. They weren't being taken care of. And so restraints did become a very big, it was a symptom of a bigger problem, but very real. And I think I would be open to including providers, but I'm not for just taking this out and pretending like hospitals have not been culpable in regards to inappropriate restraining, because they have.
Committee, other questions or comments? Senator Thompson?
Madam Chair, would you accept a substitute conceptual amendment that reinstated the restraints portion and added for the safety also of medical personnel? In other words, lines 11 through 15 put back in, but also add the language that to ensure the physical safety of the patient, other patients, or medical personnel upon the written.
I actually had that in the notes that I was taking as
Okay,
well,
so
that we could add.
I don't know if you want to do it as a
Of the
substitute amendment or
medical
vote on this
personnel.
amendment. It's up to you, Madam Chair.
And I see Senator Petty, and I know that you had another amendment, so would you like to address this?
I actually have that amendment. I have a copy.
Yes, while it's being passed out.
Thank you. You know, I am getting a look at this. There's just kind of ongoing thinking here. Chemical restraints is incredibly important in there as well. That was a huge problem with the COVID treatment. They were just pouring narcotics and such to these people and inducing chemical restraints. So I would really prefer not to see that go away. I think that's a step in the wrong direction.
All right, committee, let's do it this way then. Let's vote on the Senator Blasey's amendment first, and then we will vote on Senator Petty's amendment.
Madam Chair,
Yes.
I see, just before we vote on my amendment, I see that Senator Petty's amendment keeps in the words involuntary seclusion, which I understand adding physicians or providers for their safety, but involuntary seclusion, again, is also sometimes warranted when you have patients screaming profanities over and over and over and throwing feces, and I don't know if that's necessarily a threat physically to another person, but it's certainly their mental.
If I may, Senator Blasey, it says the right to be free from physical, but then it also says, but restraints may only be imposed to manage harmful behaviors or order of the physician. I feel like it's stating, correct me if I'm wrong, the first sentence is saying you have the right to this, however, restraints may only be imposed to manage harmful behaviors, physical safety of the patient, staff members, other patients.
Right, but it says, so for the purpose of discipline or convenience. I mean, could you say convenience as well? They're screaming profanities right and left. I mean, is that a convenience? And it's not to treat their patient's medical condition, it's just because they're screaming.
Would they restrain someone because they're screaming?
No, it's the involuntary seclusion portion. When you have to put in another room, door, you know, maybe they don't want to be secluded per se.
Okay, I tell you what, yeah, we need to vote on your amendment first, Senator Blasey. And then we can, perhaps that can be addressed in Senator Petty's. So committee, are you prepared to move your amendment?
I move my amendment.
Do we have a second? Senator O'Shea seconds. Committee, all in favor, say aye. Opposed? The noes have it. We are now moving on to, yes? Okay. All in favor? Danola's taking notes, goes, ah. Okay, committee, all in favor of this amendment, raise your hand. In favor of. Seeing 4 hands. Opposed? Chair breaks the tie. Now we move on to Senator Petty's amendment. In favor. Yes.
Thank you, Madam Chair. You had asked the question of did restraints or seclusion
Right.
appear anywhere else in statute? Just kind of doing a really brief search.
Yes.
There are provisions in the care and treatment for persons with alcohol and substance abuse problems, and also in the Crisis Intervention Act. And it appears to be pretty much the same provision, just kind of.
The Crisis Intervention Act allows what?
And this and the Act for Care and Treatment of Persons with Alcohol and Substance Abuse Problems, its restraints or seclusion shall not be applied to a patient unless it's determined by the head of the Crisis Intervention Center or a physician or a psychologist to be necessary to prevent immediate substantial bodily injury to the patient or others, and that other alternative methods to prevent such injury are not sufficient to accomplish this purpose. Restraints or seclusion shall never be used as a punishment or for the convenience of staff. The extent of the restraints or seclusion applied to the patient shall be the least restrictive measure necessary to prevent such injury to the patient or others, and the use of restraint or seclusion in a crisis intervention center shall not exceed 3 hours without medical reevaluation, except that such medical evaluation shall not be required unless necessary between the hours of 12 midnight and 8 a.m.
And this is for a crisis center?
Yes.
Thank you. I'm sorry, so I guess my vote was unclear. I oppose the amendment. Now we're ready for Senator Petty's amendment, and is there any discussion? Senator Petty.
Thank you, Madam Chair. So I think this amendment does address some of the conversation that's been going on. And as you can see, as Senator Thompson had mentioned earlier about the restraints may only be imposed to manage harmful behaviors, and then adding the part about staff members, I think as a conceptual addition to this would be removing the words involuntary seclusion, which are in line 9, and then that would address the issue about involuntary seclusion. This particular amendment was asked for from Children's Mercy, and one of the things was that currently, as the bill would be written, it's not consistent with the Joint Commission's regulations and CME rules, which allow hospitals to use restraints or to manage harmful behavior and ensure safety of patients and staff. So that's my amendment. I move my amendment with the conceptual change.
Other discussion, I was along the same lines that you were, Senator Petty, but instead of striking involuntary seclusion, move it down here where restraints and involuntary seclusion may only be imposed to ensure the physical safety of the patient, staff members, other patients, and leave it down there. Senator Blasey.
I guess I appreciate that. My question is, since it's physical safety, is throwing feces, I guess, physical safety, and screaming profanity physical?
Not necessarily.
Senator Baumgartner.
And staff members is included in there too, in the amendment.
Senator Stefan.
Thank you. That certainly falls under a psychiatric behavioral problem and warrants to be treated along those lines. You got that, or you got somebody breaking laws in which the police can become involved. But writing a law to try to prevent that's going to be difficult.
Senator Baumgartner.
Thank you, Madam Chair. So with the conceptual of moving involuntary seclusion is the carrier of the amendment and the conceptual amendment willing to put in the requirement that we heard from the revisers about requiring a check every 3 hours? To put someone in seclusion and to not mandate a check is dangerous. Thank you, Madam Chair.
As the maker of the amendment with, and I do agree with moving the restraints and involuntary seclusion, moving the terms involuntary seclusion to line 11, I do not agree with making any other changes to this amendment.
So you are agreeable to put "and involuntary seclusion" after the word restraints on line 11 in your amendment?
Yes, that's correct.
Are you prepared to move your amendment?
Yes, I move my amendment.
It's been moved and seconded by Senator Blasey. Committee, all in, yes.
I would like that read, so it's all put into context, please, before I vote.
Jenna, could you read that to us, please?
So line 11 would read, restraints and involuntary seclusion may only be imposed to manage harmful behaviors or to ensure the physical safety of the patient, staff members, or other patients. And then we'll have, I'll probably add a subsection or a subparagraph A with the language about the checks every 3 hours, if that was agreed to. Okay, that was not agreed to, sorry. So then we will not have that.
Committee, all in favor of this amendment as amended, please say aye. Aye. Opposed? I don't think roll call is necessary. The chair has determined that the amendment has passed. Okay, committee, now we're back on the bill unless we have
Madam
other
Chair.
amendments. Yes, ma'am.
We are well past our time. We have other obligations.
Yes, we do. Committee, we are meeting at 1:30, so, but all we have left on this bill is to vote on this bill.
Well, because
Do we have other amendments?
then my amendment would be to add the language of the 3 hours.
I have another amendment on this one, too.
All right, we will recess until 1:30, and we'll begin with 352.